Hello guys. So today we are going to talk on topic called pregnancy toxemia. So it is a disease of intensive farming system, which means that the animals are housed in confined conditions, not like open ranging system. So the synonyms are ovine ketosis because it mostly occurs in sheep than in goats. It is also called gestational ketosis or toxemia. It is also called twin limb disease or pregnancy disease because it occurs in last 6 weeks of gestation mostly. So that's why it is called a pregnancy disease. So it is also called ovine ketosis. So why ketosis occur? Because of this hypoglycemia. So hypoglycemia occurs due to two reasons. First reason is the glucose requirement of the uterus increases up to 40% of the total liver glucose output, which means that uterus requirement is increasing, but the liver, it is not giving the sufficient glucose, so it will go into hypoglycemia. And also the dry matter intake of the animal reduces from 130 day. It goes from 1.5 kg to 1.25 kg. The second factor which causes hypoglycemia is the mainly endocrinological status. What happens is the levels of growth hormone, progesterone, and prolactin. These levels in late pregnancy tends to increase, and also the insulin level decrease. So which causes what? Hypoglycemia. So these are the two factors which causes hypoglycemia, which leads to ketosis and then ketonuria, ketonemia, and which causes the disease. So etiology. Coming on to etiology, as I told you, it is mostly occurs in last 2 months or last 6 weeks of gestational period. That's why it is called pregnancy disease. It can occur in the cold weather conditions because the feed won't be there, so animal won't have sufficient feed to eat on. Sudden increase in energy demand is also a reason for pregnancy toxemia. Decreasing stomach space to hold forage due to growth of unborn lambs and kids. Malnutrition is also a cause of pregnancy toxemia. So while looking at a doe which is prone to pregnancy toxemia, BCS comes into condition. See, BCS should be around 2.5 to 3, so that animal won't go in pregnancy toxemia. Too thin or too fat animal will definitely cause the condition for disease. So what types of pregnancy toxemia? First is primary pregnancy toxemia, which means animal in gestation period which having hypoglycemia, which cause ketosis. So this kind of pregnancy toxemia is called uh, primary pregnancy toxemia. So if a doe is fatty, means the liver of the doe is fatty, which cannot give glucose up to needed level. So it causes ketosis again. Starvation pregnancy toxemia means there is no energy. So whatever stored fat or anything is there, there will be NEFA will be there, non-esterified fatty acid. Everything will lead to ketosis and then ketonemia and finally ketonuria. So ketone bodies can also be, this ketone in urine can be detected by a test called Rothera's test. Secondary pregnancy toxemia can occur due to sporadic conditions like footworm or worm burden. So coming on to epidemiology, as I told you, it mainly occurs in sheep because generally sheep will give per parturition one kid, one lamb, and goat have tendency of twinning. So mostly the animal like sheep have only one fetus during one gestation. If it have more than one fetus, the chances of increasing the disease is more. As I told you, if the fetus is in large size, the chance of demands of energy will be increased, therefore chances of the disease increases. Same in condition of fetus, one fetus, two fetus, and three fetuses condition. Coming on to pathophysiology, as I told you, feed intake does not meet energy demand. If energy demands are increasing and feed intake is less, So what will happen? Insufficient normal production of propionic acid. This propionic acid is very essential because it will lead in the Krebs cycle the formation of oxaloacetic acid, which is needed for a Krebs cycle to run onto. So if propionic acid is not there, not enough glucose, so there will be hypoglycemia and low blood sugar will be there. The low blood sugar makes her metabolize fatty acids and glycerol, and this fatty acid now, since there is no oxaloacetic acid because of low propionic acid, Krebs cycle won't occur, and this acetyl coenzyme will go into ketosis, and we will see the ketone in urine and milk. Coming on to clinical signs, the first most clinical sign observed is disorientation and isolation from the flock. We can see nervous signs like stargazing, also called opisthotonus. The clinical signs observed are there will be incoordination and falling. See, you might have remembered there are ketone bodies like BHB, beta hydroxybutyrate. One is acetic acid, one is acetoacetic acid. This will convert into isopropyl alcohol, and it will go to brain, and it will manifest signs like incoordination, tremors, and everything. So if the doe become or sheep become recurrent for 3 to 4 days, and if it not treated, obviously there will be a fetal death. If it recovers on its own, and if treatment is not done, relapsing will be seen. If fetal death occur and it is not terminated pregnancy, then maternal septicemia or endotoxemia can be suspected, and obviously that will occur. We can also see concurrent hypocalcemia and hypomagnesemia, which further leads to this incoordination and falling. Obviously, the nervous signs. So, what lesions we can observe during pregnancy toxemia? The lesions we can observe is hepatic lipidosis can be seen due to stress. The enlarged adrenal glands can be seen. If the animal is gone for postmortem, and if we see uterus, we can see multiple fetuses in decomposition state. And if very thin eaves carcasses are found, we can see the gelatinization of the fat. The fat around kidneys, the fat around heart, and subcutaneous fat mostly occurs serious atrophy of these kind of fat. So how you will diagnose a pregnancy toxemia? Basically, pregnancy toxemia can be diagnosed based on clinical signs. As I told you, it will be separate from the flock. It will be depressed. In later condition, it can be a recombinant animal. We can see nervous signs like opisthotonus. You can go for ultrasonography by seeing multiple fetuses, and we can conclude that okay, this is a case of hypoglycemia, or it can be the case of hypoglycemia. We can see the clinical pathology, like we can perform test for glucose level in the urine or in serum, but generally you may or may not find hypoglycemia, or you can go for ketone body analysis, which is beta hydroxybutyrate. The levels less than 0.8 millimoles per liter is normal, but if it is more than 0.8 millimoles per liter, the disease is subclinical. And if it is more than 3 millimoles per liter, obviously you will see all the clinical signs. Not all, mostly all clinical signs you can observe. There will be, if you estimate urine, you can also see. Uh, if you estimate serum, you can also see hypocalcemia and hypokalemia. So how you will differentially diagnose a pregnancy toxemia case? If it is a heart problem, you can suspect hypocalcemia, which gives nervous signs. You can suspect enterotoxemia or pulpy kidney disease. You can suspect rabies. You can suspect listeriosis because it causes circling or nervous signs. You can suspect polyencephalomalacia, which is nothing but same stargazing posture, which occurs due to thiamine deficiency. You can suspect lead and copper poisoning, or the simple acidosis can be suspected. If it is an individual problem, you can suspect brain occupying space occupying lesion in brain, or you can suspect disease of middle ear, or you can suspect sarcocystosis or GID. So what treatment we will give? So before onset of recurrency, we can give glucose and its glucose precursors. Parental glucose administration, like we can give 5 to 7 grams of glucose IV 6 to 8 times in a day. We can give CBG, which is calcium borogluconate 23% at the rate of 25 ml IV to check any hypocalcemia. To check hypokalemia, we can give potassium 10 to 20 milliequivalent per liter. To check ketoacidosis, we can give sodium bicarbonate 5% 10 to 20 ml IV, and we can give dextrose 25 D25, which is at the rate of 25 to 50 ml IV. We can also give insulin long acting at the rate of 0.4 IU per kg subcutaneous. This propylene glycol, which is a glucose precursor, can be given 60 to 90 ml orally per day. For prophylactic antibiotics to check septicemia, we can give broad spectrum antibiotics. If we suspect that fetuses are dead, we can induce kidding by dexamethasone at the rate of 15 to 20 mg IV or IM. If fetus is live, we can go for C-section, and if the animal is severely depressed and anorectic, we can go for NSAID called flunixin meglumine at the rate of 2.5 mg per kg SID. Pregnancy toxemia prevention. Main thing is Eve or doe should not enter the last 6 weeks of gestation with a BCS of less than 2.5. We should not let Eve or doe consume large quantities of molasses, which will cause acidosis. Supplement high energy fields during last 4 to 6 weeks of gestation. We can identify the Eves and doe with multiple fetuses by ultrasonography, and we can feed accordingly. We can give monensin and lesol acid to enhance feed efficiency. That's it.